As healthcare providers, we work in a hospital or some healthcare facility. We experience our communicative interactions with those we serve in a designated setting. We have an advantage. Dare I say, it may even be seen as a systemically designed privilege biased towards our needs rather than the patient's, causing a power imbalance. This power imbalance affects the flow of conversation. With more than 3 million members, the nurse profession is the largest segment of the nation's healthcare workforce, giving us opportunities as nurses to interact with patients more than any other healthcare industry sector. The nurse shares with society the responsibility for initiating and supporting action to meet the health and social needs of the public, in particular those of vulnerable populations. I begin to wonder, is this really serving our community? The community? Are we in the community? This caused me to go into an analysis and multiple looping back to assessing how big of an effect does this factor of insufficient knowledge of the community contribute to the nurse-patient relationship barriers that are developing and affecting care every day in the state and even in this country. Participants using a voluntary survey method at the 3 largest hospitals within a 20-mile distance from my home. The survey included 10 nurses and 15 community members. Of those 15 community members were active patients, including 5 community leaders. The results of the survey data showed 6. Patient-nurse communication, language, misconception, and pain. Patient-identified nurse characteristics of identified barriers included lack of knowledge, all-knowing attitude, work overload, and work dissatisfaction. The environmental related barriers of being in a hospital included noisy environments, patient new to the hospital unconducive environment for effective therapeutic communication. Many nurses don't want to actually work in the community that they live in to keep healthy professional boundaries, to separate their social personal relationships from their interactions in their nurse-patient relationships, to prevent overlap. How can we holistically serve a community represented by an individual that we care for in the hospital when we have not been in the community? Yes, we drive, carpool, or some form of long-distance transportation to a hospital that has been implanted in these environments. And then we travel back home, wherever that may be. The majority of nurses cannot tell you the name of 5 essential structures of the community, where the local pharmacy, grocery store, or police department is located. Most nurses cannot name the 4 streets of the block the hospital that they work at is located on. The studies showed nurses with careers at these hospitals stretching back more than 2 generations of that community could not answer these 2 questions. This brought me to my core question. How can we, or is it not possible that we, the nurses as nurses, can give and create a caring professional environment that has the evidence of this by inclusion? The answer is yes, and it is shown through the 5 I's of integration and connection with a community. A study performed by the University of Texas at Arlington stated this: when the nurse can understand the challenges people face, this direct experience can be life-changing for the nurse, causing some to change directions in their careers and for some to begin to enact change. The innovation would be by creating collaborative intercoordinated frontline plan of action with the Washington Nursing Commission, Washington's Department of Health, Washington State Nursing Association, and the Association of Colleges of Nursing, Washington State's nursing educational institutions. The patient-centered care can be accomplished when there is collaboration between different stakeholders in the community and the nursing field, resulting in an increase in patient adherence to care, further producing increased health of each individual, and collectively creating a protection factor to be developed in the community's resiliency. My nursing innovation has 3 phases. The first phase belongs to the novice nurse, and is where I will be presenting most of my information for during this presentation. The novice nurse, who will soon be you and I, are right now initiating their entry into the nursing field. With our fresh perspectives and new evidence-based research and education, this is the optimal place for us to start being able to include ourselves into the community and bring inclusion into our practice. In 2016, the National Center for Interprofessional Practice and Education launched a $2.5 billion initiative to help 16 nursing schools develop new community-based clinical programs. The purpose of this initiative was to give these nursing schools and their students the ability to create development of innovative ways to integrate nursing and other professional students learning while engaging students to meet the health needs of the community. They stated, creating a level playing field between academic institutions, their students, and the communities they serve. The initiative is also about teaching nurses and all health profession students what it means to truly partner with the community they serve. The final phase is focusing on already practicing nurses and hospitals. The Washington State Nursing Association stated in their Social Determinants of Health document, nurses working for companies who base practices outcomes in comparison to healthcare cost reform, who are not articulating or being understood about patients' outcomes, is a critical factor and barriers between the nurse-patient relationship, affecting the health of each patient and the communities. I title my nursing innovation, Come, Let's Cause and Create Community Connections. The reason for this title and the foundation for my nursing innovation comes from the International Code of Nursing, Code of Ethics, first element of the code. It states, nurses share with society the responsibility for initiating and supporting action to meet the health and social needs of the public, in particular those of vulnerable populations. The second comes from the Washington State Nursing Association, which states, nursing and the first step towards building a culture of health is the nurses' acknowledgement and implementing in their practice that health starts in our homes, schools, and communities. As seen in the data chart, the result will be a direct benefit for the nurse. Due to the early exposure in their nursing practice to the community source, a nucleus of the patient served at the hospital will cause the nurse to grow seamlessly a nursing practice where nursing skill competence is developed with an equally competent patient-centered approach and application. I would like to say in my conclusion that there is area for further study. There is not much documentation from actual community nurses, and I would like to also address that this is without considering outside personal, socio-economical benefits or deficits that each individual and each nurse has or has had in their personal lives, due to the need to have the ability to have some consistency with evidence for this innovation study project.